Hi everyone, we are here, Dr. K and Dr. H, going to go over the midline ridge for you for the spine, and also we'll do trail guide number 2, why we're here, which is crossing paths. So if you just have your patient, if they're sitting up nice and tall in anatomical position, we're not quite sure. You can see some of the spinous processes on some of your patients, but maybe not on others. If you have them flex forward, and on Dr. K, you can really start to see her spinous processes as they come out. You'll also appreciate that there's the nice space in between those spinous processes. This is important for us to know because when we are actually mobilizing a joint, we're going to need to know, are we actually on the spinous processes? Are we in between those spinous processes in the intervertebral space? Or if we go out, are we now going to be on the transverse processes and doing a unilateral glide throughout our mobilization? Great. So from there, let's now start on our bony landmarks. In the simplest form, we can either start top down or bottom up. And it's really up to you and your preference on how you want to orientate yourselves. You want to get used to doing both so that way it's quick in the clinic and in your practical situation. So if we want to start with the bottom up approach, we can go at the iliac crest. So again, you're going to kind of curve around that ilium, sink down in so that you know you're actually on the iliac crest. If you come straight across, that should be L4. If you're not sure, you can now count your way down because you know that you've just seen all those beautiful spinous processes, and you can count yourself L4, L5, and then you should be at the top of the sacrum. If we're at L4, now we can move up and we can give ourselves an orientation to the thoracic spine through our 12th rib. So if you come down, and you can see on Dr. K as she starts to have the curve within her waistline, that's really where I'm thinking that her 12th rib might be. If I'm not sure if I'm on it, I can palpate towards the front of her body to see if that rib stops articulating around. And if I'm really on it, I can also see because that 12th rib is very mobile. So if I give just a light pressure in, I can tell that I'm at the 12th rib. If I draw a straight line, again, now I'm at T12. If you're not sure, you're always going to orientate yourself to the landmarks below or above. We're going to move to the inferior border of the scapula. But again, we've talked about this quite a bit, but you need to make sure that your patient is sitting up nice and tall, also in anatomical position, which will change the position of your scapula from being in a protracted state, so more forward on the body, to a retracted state. So again, for me, I'm going to find the medial border of the scapula, come down to that inferior angle. For me to make sure, I like to cup it in between my hands to make sure I'm there. I can then draw a straight line over and find T7 at that point. Again, you're going to always reference that to the ones above and below. So I could sink down, count my way down to see where I'm at, and once I get to T12, in my idea, I can now roll my finger outward and find if I'm now on that 12th rib to make sure I'm referencing myself appropriately. So from T7, now we're going to go up to the spine of the scapula. Same thing, patient should be up nice and tall. So that way now you're looking at the spine of the scapula. As the spine of the scapula comes straight across, you should be at T2. Some of our other references might tell us we're at T3. If you look at our anatomy books and a lot of different spines, you'll see sometimes it actually is in between the T2 and T3 junction where the spine of the scapula is. So again, these are landmarks that we're going to reference, but we're always going to make sure we reference above and below to make sure we're there. Our really last one that we're going to do is C7. And on Dr. K here, if she looks up nice and tall, you'll see that she has this nice prominence that sticks out. As we learned, it might be easiest to stick your middle finger on C7 and stick your index finger on C6 and ask your patient to flex forward, and C6 should pop into your hands, and C7 really should not move underneath of your hands. So that might be a nice way for you to reference where you're at in relationship to the body and in relationship to the spine.